Welcome to PEM Currents, the Pediatric Emergency Medicine Podcast. As always, I'm your host, Brad Sobolewski, and today we're talking about pertussis, a disease that is challenging clinicians and public health officials alike. Despite being vaccine preventable, pertussis is on the rise yet again, fueled by declining vaccination rates, waning immunity, and the fact that people can't stop coughing on each other. In this episode, we'll go over clinical presentation, diagnosis, management, infection control, and post-exposure protocols. So pertussis, or whooping cough, is caused by Bordetella pertussis, a gram-negative coccobacillus. Definitely spreads via respiratory droplets and has no environmental or animal reservoirs, making humans the sole carriers. The incubation period averages about 7 to 10 days, and the disease progresses through some distinct clinical stages, which I will go over in a moment. Pertussis has been recognized since the 16th century. I was not practicing medicine back then, with the first documented epidemic occurring in Paris in 1578. Bordetella pertussis was isolated in 1906 by Belgian researchers Jules Bordet and Octave Gengu. Hopefully I pronounced them right, but they're long gone, so they won't be mad at me, leading to the development of a whole cell pertussis vaccine in the 1940s. Introduction of the DTP, the diphtheria tetanus pertussis vaccine, dramatically reduced disease incidence overall. In the 1990s, we got the acellular pertussis vaccine, the DTaP, which replaced the whole cell formulation due to concerns about some side effects. So pertussis remains endemic in many regions of the world despite vaccination efforts. During the 23-24 school year, DTaP coverage among kindergartners in the United States dropped to 92.3%, which is below the 95% threshold needed for herd immunity. That is why we're seeing an outbreak now. This is a pretty troubling trend that began during the COVID-19 pandemic and has just gotten worse since. The exemption rate for vaccines rose to 3.3%. This is the highest on record. Non-medical exemptions accounted for over 93% of these exemptions, and 14 states in the U.S. have reported exemption rates exceeding 5%. Idaho is leading at 14.3%. So the implications of these declining vaccination coverage rates are significant, and that's why we're seeing more and more outbreaks, especially putting our vulnerable populations at highest risk. All right, let's get back to the clinical presentation. Wait, what's that sound? Hold on. Yeah, so that's the whoop and the cough of pertussis. And I'd wager that many of you have not yet heard that clinically, so that's why I included it on this episode. So here's the stages of disease. First is the catarrhal stage, which lasts 1 to 2 weeks. You have rhinorrhea, mild cough, and a low-grade fever, if any. You are highly contagious during this phase, but it's often unrecognized as pertussis. Then, in the next 2 to 8 weeks, you have the paroxysmal stage. You have these severe paroxysms of coughing, the inspiratory whoop right beforehand, post-tussive emesis. Infants, especially under 6 months of age, may present atypically with just apnea, cyanosis, or bradycardia. Following that, you have the convalescent stage, which lasts weeks to months. You have gradual resolution of symptoms, though residual cough may persist. That's why they call it the 100-day cough. Aside from coughing forever, there's some important complications you need to be aware of. And they can be severe, especially, as I noted earlier, in young infants. So respiratory complications include apnea, secondary bacterial pneumonia, and pulmonary hypertension. Children can have seizures or encephalopathy, often due to hypoxia. And the mechanical complications can include rib fractures, subconjunctival hemorrhage, and even rectal prolapse due to intense coughing and Valsalva. Greater than 50% of kids under 12 months of age with pertussis could require hospitalization. 50% of those kids will have apnea, 20% will have pneumonia, and up to 1% will die. Encephalopathy occurs in about 20% of mortality cases, probably due to hypoxia or maybe the toxin produced by the bacteria itself. So making the diagnosis of pertussis starts with high index of clinical suspicion. Early diagnosis, as you'd suspect, is critical to limiting disease spread and initiating treatment. So PCR testing, which is widely available now, has high sensitivity in the first 3 to 4 weeks and is the preferred diagnostic test. Culture is the old gold standard, but it's slower and less sensitive. It can take up to a week to grow. CBC might show significant lymphocytosis, most often in infants, but it ain't going to make the diagnosis of pertussis for you. And a chest x-ray will just show you some non-specific findings, such as peribronchial thickening in severe cases. And unless you're worried about concomitant bacterial pneumonia, you probably don't need a chest x-ray to make the diagnosis of pertussis. You can get an isolated pertussis PCR, or it can come as part of a respiratory panel. But remember, those comprehensive viral respiratory panels cost $1,600. So if you're just worried about pertussis, don't get the whole panel. So management starts with supportive care. Infants with apnea, cyanosis, or feeding difficulties should obviously be admitted to the hospital. They may need oxygen and or nutritional support, and you definitely have to watch those kids very closely for the complications such as hypoxia and secondary infections. Remember, a tiny baby with pertussis can go apneic at a moment's notice, even without a persistent cough. Antibiotics reduce transmission, but do not significantly alter disease progression once the paroxysmal stage begins. So again, you are treating with antibiotics to prevent more people from getting sick, more so than shortening the duration of illness. The main antibiotic that we use is azithromycin. For infants under 6 months of age, that's 10 milligram per kilogram daily for 5 days. For children older than 6 months of age, 10 milligrams per kilogram, max of 500 milligrams on day 1, followed by 5 milligram per kilogram per day, max of 250 milligrams on days 2 through 5. That is the same dosing that you can give to a grown-up. An alternative treatment would be trimethoprim sulfamethoxazole for patients who are allergic to macrolides. Post-exposure prophylaxis is recommended for household contacts, so the people that the index patient lives with, any high-risk individual, an infant, pregnant women, or immunocompromised individuals that have been in any sort of contact with a person with pertussis, and a healthcare worker exposed without appropriate PPE. Again, pertussis spreads through respiratory droplets, so this necessitates strict infection control. So that starts in triage. So if you think that a patient has pertussis, then they need to be placed on droplet precautions as soon as they are assessed. You wear a surgical mask and eye protection, so goggles or a face shield, and you want to maintain these precautions for 5 days after starting effective antibiotics, or for 21 days if the patient is untreated. As a clinician, just ask yourself, did you wear appropriate PPE, mask and goggles? Don't get lazy. Was the exposure prolonged or close? And rely on infection control in your institution to help decide whether or not you need post-exposure prophylaxis. If you're vaccinated and you wore PPE, you don't need anything unless you have symptoms. If you're vaccinated and you did not wear PPE, then prophylaxis is recommended. If you're unvaccinated and not up to date, well, then what are you doing in healthcare? An immediate prophylaxis and vaccination update are required. And okay, because I just mentioned it, let's talk about vaccines. So first, I want to talk about DTaP, DT, lowercase a, uppercase p, and Tdap, uppercase T, DAP. So DTaP contain higher concentrations of diphtheria and pertussis antigens. It's used for children under 7 years of age. Tdap contains lower antigen concentrations, and it's designed for adolescents and adults to reduce reactogenicity. There is no standalone pertussis vaccine. I've had patients say, well, I don't want tetanus, just give me the pertussis one. Well, tough shnikes. We do not have a pertussis vaccine alone. It's only available in combination with diphtheria and tetanus toxoids, DTaP or Tdap. The combined vaccine boosts efficacy and ensures broader protection against all of the included infections. Now, the routine vaccination schedule, which if you are a pediatric resident, you know like the back of your hand, the DTaP is administered at 2, 4, 6, and then between 15 and 18 months with a booster at 4 to 6 years. The Tdap is one dose at 11 to 12 years, and then during every pregnancy to confer passive immunity to the newborns. And again, depending on when you're listening to this, you may be in the midst of a pertussis outbreak. And if you listen to this a few years later after the original publication date in the fall of 2024, and you're seeing another pertussis outbreak, well, dang it, we haven't done our job. We need to strengthen school vaccination requirements. We need to educate parents about vaccine safety and the risks of exemptions. And we need to broadly improve and ensure access to vaccinations through our community clinics. All right, so that's it for this episode on pertussis, which remains a significant public health challenge due to its severe complications in young patients and the ongoing decline in vaccination coverage. Healthcare providers play a vital role in diagnosing and managing it, preventing its spread, and educating patients and families about the benefits of vaccination. Infection control practices and post-exposure protocols are critical for protecting both clinicians and close contacts and other exposures. Thank you so much for listening to this episode. I hope you found it educational and informative. If there's other topics that you want to hear about, let me know. I'm on X, I'm on Blue Sky, I'm on Mastodon. I take emails. You can leave a comment on the blog. You can leave a review on your favorite podcast site. Any feedback is good feedback. And encourage your colleagues to listen, and as the kids say, like and subscribe. I told my 12-year-old I would say that at the end of the episode. For PEM Currents, the Pediatric Emergency Medicine Podcast, this has been Brad Sobolewski. See you next time.